So welcome everyone to the Initiative for Agency and Development Public Talk series. I am Tauhidur Rahman, a professor in Department of Agricultural and Resource Economics and Economics with courtesy appointment. I am also the founding director of IfAD, the talk series you are attending. For new participants who are for the first time joining us for this talk, IfAD is university-wide initiative at University of Arizona. Our mission is to promote solutions to the problem of poverty, agency, and development. We bring together researchers from economics, law, behavioral sciences, and work with international institutions, particularly United Nations institutions, foundations, governments, and communities around the world to promote the solutions of economic development problem. In particular, our philosophy is that individual agency, collective agency, group agency is the foundation for individual progress and societal progress. And also, agency is also the foundation of why some companies, some organizations keep reinventing and others do not. So that is our core theme. With that said, now it is my pleasure to introduce you our distinguished speaker, Dr. Neil MacKinnon. And it has been long term in planning. So I'm very glad that he is here today and agreed to give a talk. So Dr. Neil MacKinnon is the president of Central Michigan University today. He joined a few months ago. Before he joined CMU, he served as a vice provost and executive vice provost of Augusta University, where he was super provost. Basically, he transformed in a short period of time Augusta University. Before that, he was dean of James L. Winkle College of Pharmacy at University of Cincinnati. Before that, we had a distinction of and pleasure of having him as a colleague at University of Arizona. He was professor of public health at our public health college, and he was also the director for Center for Rural Health at University of Arizona. Dr. MacKinnon received his bachelor's in pharmacy from Dalhousie University, master's in hospital pharmacy from University of Wisconsin, and doctorate in pharmacy healthcare management from University of Florida. One thing I want to tell you, which is really, really important, Dr. MacKinnon's research interest includes a wide variety of range. He works on the issues of rural health, health policy, patient safety, community pharmacy. Now, one thing personally I want to tell you is that he is arguably only president today in the United States, anywhere, who is as active as a researcher scholar as anyone knows. That is one thing. Another thing, if you look at his bio, all of his work has been motivated by making real impact among the communities who are historically disadvantaged, whether he was a director of rural health at University of Arizona, then going to Cincinnati, and then ending up at University of Augusta, transforming it, and now his choice of university, is at Central Michigan University. So there is a common theme. He is motivated by societal impact, which is personally, at a personal level and professional level, those who know me, is very much what motivates me, that being useful for the causes, social causes, and other things. So it is, you can see, in addition to, you will see the range of his scholarship he will share. It is true honor to have him today among our distinguished series of IfAD public talk for the last 5 years we had. So now, before I hand to Dr. MacKinnon, few logistical issues that he's going to talk for about 40 to 50 minutes. And of course, he can talk for 5 hours. That's perfectly fine. And then, so question answer session. So he will talk to 40 to 45 minutes. And after that follow-up, we will have a Q&A. And when you have a question, you just use the Zoom feature, raise your hand. You directly can ask him questions. So I'm not going to be in between, and we will have a lively discussion. With that said, thank you, Dr. MacKinnon, for joining us. Now the stage is yours.
Well, thank you so much for those very kind remarks, Dr. Rahman, and just for the invitation to be part of this today. And yeah, I'm looking forward to this. It's been a long time coming. I know we've been talking about this for a few months, but today's the big day. Thank you, even for those that this is the first time we're meeting each other. Thank you for taking a chance of spending some of your Friday with Dr. Rahman and I. And I do see a few familiar faces. Want to acknowledge Dr. Dan Dirksen, who was my successor at the Center for Rural Health and has just completely elevated that institution. I see Jill, Jean, and a few others as part of his staff. You're really blessed at the University of Arizona because you may not know it, for those of you that work there, but you actually have a state office, the State Office of Rural Health, which is housed in that center. Most states, the State Office of Rural Health would be in the state capitol, in the Department of Health. But in Arizona, it's actually housed at the University of Arizona. So you have this tremendous resource. They partner with other key partners like AHEC and such. But certainly, if you've not met Dr. Dirksen yet and his team, they are an incredible resource. Their goal is to address rural health issues in the state of Arizona, increasing access, improving quality and safety, and decreasing costs. I also want to acknowledge Dr. Prashit Abade. Prashit completed his Doctor of Public Health at the University of Arizona. He then did a postdoc with me at Augusta University, and he's now faculty at the College of Medicine. So some of the work today he's been involved in as well. So again, looking forward to presenting here. Let me get a start here and share some slides, if that's okay with everyone. All right, can folks see that okay? We're good, all right. And there you have my Instagram handles. That's the real way out. I know when we have snow days here in Michigan, I get lots of messages on Instagram from my students, but now you've got that, and that's one of the easiest ways to connect with me. You've got my Instagram handle. Well, as Dr. Rahman said, way back in the day, I was at the University of Arizona. I found a picture from around that time frame. So this is my wife and I on Mount Lemmon, of course, that overlooks Tucson with our 3 daughters. They are now all at the University of Georgia. They are now all at the University of Georgia. So you can see how time has really passed with that.
Good picture.
Thank you. So really today, just 2 primary learning outcomes that I wanted to include today. The first one, we'll talk about this issue of geographic health disparities. I'll start locally in one state, then spread nationally across the US, and then end with some global examples. And then most importantly, I think really is what's the take home for you today? And so we'll talk about how, whether you're a researcher, health policy analyst, a clinician, an academic, how potentially you could play a role in reducing these geographic health disparities. But I do want to start with a video. So as soon as I start sharing there, I'm actually going to stop right now because I'm going to go into YouTube. So let me kind of set this up for you as I get ready to share this. And so I'm originally from Nova Scotia, Canada, which is on Canada's east coast. And if you go a little further north towards Greenland and Iceland, there's another province called Newfoundland. It was actually a British colony until 1949, very isolated. So the clip I'm going to share with you, it's a fictitious movie. It's a trailer for that movie, but man, it really hits home. And so the movie is called The Grand Seduction, but this is not an R-rated movie. The movie is about the lengths to which a little fishing community will go to recruit a physician. So this is the backstory before you see the trailer, is that they do not have a physician in this community. There's a plant that's offering to relocate to this island with lots of high-paying jobs, but the catch is they have to recruit a physician. And so there's actually a physician, a newly graduated physician, who's going to spend 1 month on this island on a rotation. And their job, there's only 120 people that live on this island, is to make this the most appealing place on the planet. And so the reason I'm going to show this, it shows the lengths to which some communities will go in rural communities to addressing healthcare needs. So I'm going to, now that I've set this up, hopefully this will work and we can watch this trailer together.
Did you want sound coming out of this?
Neil, there is no sound in it. Did you mean to have
Oh,
sound?
no sound? Oh, no.
Maybe we can start it.
All right, well, let me stop that. Well, sorry about that. I was sound on my end, but just no sound on your end. So let me I guess we'll have to have a trailer. Maybe I'll send a link and you can watch that later. But that movie, again, it's called The Grand Seduction. Really funny because, for example, there's 120 residents on this island. What they keep going is they move around the different parts of the island. So he thinks there's more people that live there than they do. They find out in his research that he likes the sport of cricket, and they have no idea how to play the sport of cricket. And so you kind of saw that scene there where they actually get the uniform sewn. He shows up a little faster than they expected, and they have no idea what to do. So they just start celebrating, pretending that the cricket match was over. So the reason I really like that movie, again, it's fictitious, but it shows some of the challenges that our rural colleagues face in recruiting healthcare professionals. So with that, I'll go then back to the slides. Okay, hopefully folks, can you see that again?
Yes.
Okay, great. Yeah. Okay, yeah, and so kind of with the, I don't know if you see my cursor here, but this is Newfoundland in the top of the map here, again, where this movie is filmed. The next province down further south is Nova Scotia, where I'm from. And this is a picture of the high school that I went to. Just like many rural communities, Bridgewater's had challenges in recruiting physicians for years. So a few years ago, I was invited back to Bridgewater as the commencement speaker in my high school. And sitting next to me on the stage was the mayor. And we were talking a little bit before the presentation. He knew my background in Arizona, directing rural health. And so he said, Neil, what we try to do is we try to find who are the medical students that like sailing. And what we do is we have them come to our community for a weekend. We have them sail yachts and different ships down our river out to the ocean. We have a big party at the end of the weekend. And that's how we try to recruit physicians. So if you think about it, that's the lengths to which some communities are going to recruit health professionals. So that's my hometown of Bridgewater, where there's still a shortage of primary care physicians today. If you go about 30 minutes inland from Bridgewater, there's another town that's quite a bit smaller. And that town is this one. It's New Germany. In New Germany, they've had for years have not been able to recruit physicians there. And it got so bad that the community came together. They built that building you see in the top right-hand corner, rent-free for any doctor who wanted to move to New Germany. You get this office for free. You can see the people that donated the money in those bricks. They still could not recruit a physician and end up recruiting a nurse practitioner. So again, even with free rent, a beautiful space, still could not recruit a physician. And in fact, this was a sign that I took at one point when I was back home visiting my parents, and it says 2 doctors accepting new patients. This was in an urban area of Nova Scotia, outside the city of Halifax. And I've presented this slide before conferences in Canada. People are madly writing down the phone number saying, oh, this is where I can finally find a physician. And so, again, some of the challenges in recruiting physicians. Now, if you think this is just a Canada problem, that would not be correct. And here we have a slide. This is something perhaps Jill might have seen or Dan before. This was when I was director of the Center for Rural Health at the University of Arizona. And we had a conference, a national conference, where a consultant that we were working with to recruit physicians was speaking about some of the challenges of recruiting physicians in Arizona. And specifically, she was telling a story of recruiting physicians to Yuma, where they would have physicians who had just graduated from medical school. They would actually fly them from other parts of the country. And the idea is to fly them, have an interview, wine and dine them. Well, they had 2 physicians in a row that when they were flying over the desert, they of course saw something like this. The plane landed and they refused to get off. They said, you know what, I've changed my mind. I don't think I could see myself working here. So what Denise said in that conference is that they started changing it where they would fly physicians in at night and they couldn't see the desert, and they'd wake up in the morning, perhaps feel a little differently. But again, that's the kind of lengths to which some people go. And then also we have, and of course I know Dan still has this in his team today, they have a annual rural health conference in the state of Arizona. When I was director, we had, one of our speakers was Chad Campbell. He was a physician assistant and University of Arizona graduate. And he shared the story that when he graduated, he decided to take a job in rural Arizona. I believe it was the Globe area. And he recalled the story of telling that to one of his faculty members at the University of Arizona. And this is the response he got: "You're too smart for that." So in other words, why would you waste your time going to somewhere like Globe when you could work in Scottsdale or Tucson or somewhere nice? And so again, that's even that bias. And that came from an educator. That came from a faculty member at the University of Arizona. So there also seems to be this bias. Sometimes it's explicit, sometimes it's more hidden. Again, that it's a second-class place. Why would you ever think of going to a rural community? So I wanted to share with you a case study. I know we've got some clinicians today, so this is part of your world. SB is an 89-year-old female with a history of falls who lives alone in her home in a small rural town. After another fall, she's admitted to a hospital where she fails the mini mental status exam and is put on a nursing home wait list. After waiting for over a month for a nursing home bed to open up, SB develops a hospital-acquired infection and is put in isolation. 3 months later, a bed in a private care home finally opens up, but a month later, she passes away. SB was my grandmother, and this is in rural Nova Scotia, Canada. And so she was living alone in her own home. You can see she had a fall, was admitted to the hospital, and basically was put on a wait list to get to a nursing home. There weren't enough nursing home beds, and you can see what happened. She developed MRSA in the hospital and ended up passing away. So again, if we think of things accessing healthcare, in this case, accessing nursing home beds, you know, there's a human side to this too. It's not just a statistic. It's also quality of life. If I think of, you know, the last few months of her life, right, was in that hospital bed alone. And anytime I visited her, I'd have to gown up. And I remember the last time I saw her, she said, "Neil, can you take off your mask? I just want to see your face." And so again, the human side of accessing healthcare is a real challenge in many rural communities. When I was in Arizona, this was we did a few of these community conversations. This is one, of course, in Marana, not too far outside of Tucson. So I don't know if I would classify Marana necessarily as rural, but it was where we had a variety of community leaders come in and tell us a few of the healthcare issues. And so there's a report that came out of this. I want to share with you some quotes. Now, these quotes, remember, this is from 13 years ago, so you can be the judge whether they still apply to Arizona. But I know at the time, a lot of these quotes really kind of stung. They really went to the bone. And the first one, this was a quote from a healthcare professional. She said at the meeting, "There's a patient who earlier this week had a stroke. She needs extensive rehab, but her Arizona Medicaid program is expiring at the end of the month. So guess how much rehab she's going to get? Pretty much, it's going to be zero." The next quote, this came from a community leader. The cost of healthcare insurance increased 30 to 40% on average over the past 4 years, and deductibles have increased sometimes up to $5,000. Companies are no longer paying for spouses and children. The costs are too great with healthcare today. Another quote from another healthcare leader: "When you look at the fiscal health of our hospitals," in this case, the leader was talking about hospitals in Arizona, "you know you can't run a business at a negative operating margin. We have had over 45% of our hospitals in the last 4 months running at a negative operating margin. That is at a loss. This is unsustainable." Another quote from a different leader: "Hospitals at the beginning found efficiency savings through trimming and consolidation. Now we're down to the skeleton of care, and we risk quality in our ability to provide care with the next cuts." And I have one last quote. This came from another healthcare professional. "When we talk about the overall state of healthcare in Arizona, the providers are looking like the patients they are treating these days. They're hurting. They need care too." So hopefully care has improved in rural Arizona since this report was written in 2012. But certainly I know there's a lot of places around the country where this is an accurate reflection today in 2025. So when we think about rural healthcare, there's different ways to measure whether there's enough care. One standardized way is something many of you, of course, have heard of, health professional shortage areas. And there's actually different designations for this. For the next couple of slides, I'm focusing just on primary care. So this is the state of Michigan where I currently reside. And you can see Michigan has over 80 counties, so very different than Arizona. A lot of our counties are very tiny. But you can see that any of the counties that are in green, whether it's light green or dark green, those are health professional shortage areas as far as a county designation. And so actually over 70 of our counties have this designation. So you can see there's only a few counties here that are in white. In fact, if you look at the very center of the state, a dark green county there is Isabella. That's where I live. And so I'm living right now in a health professional shortage area, even though we're home of a public research university. The map on the right shows the population density of the state of Michigan. And you can see there's almost a 1-to-1 direct correlation where we have the dark red and orange colors where more people live. Those are areas where we do not have HPSAs. The one exception would be urban Detroit, which does have some health professional shortage areas. So again, almost a 1-to-1 correlation. Looking, the fewer people you have, the greater likelihood there is of a health professional shortage area. I wanted to compare that to your state, Arizona. And these are the exact same two maps. The one on the right looking at population density, and the one on the left, your primary care HPSAs. And you see almost the exact same relationship. So again, the counties that are gray in Arizona are not HPSAs. And if you look at the map on the right, those tend to be the urban areas. Again, there's a few exceptions, but generally the rule applies. So you can see this both in Michigan and in Arizona, rural areas are more likely to be designated health professional shortage areas. There's also an economic impact here as well. So this is a book that I co-authored way back in 2010 in Canada with a primary care physician. And I just want to pull out a couple of quotes from this book. And you can see, I'll just read them here for you. Hospitals, they've been called our modern day cathedrals. They are perhaps the most tangible part of our healthcare system. Communities will rally around a hospital being threatened with closure or downsizing with passion and fervor. The hospital can be a source of pride or bragging rights for the community, even helping to attract potential employers or residents. And so there's also the other economic impact. If you live in a rural community and you're blessed to have a hospital, it's probably one of the largest employers in that community with many high-paying jobs. And it's also a source of pride and bragging rights, as I mentioned here. So if you're trying to attract industry to your community and there is no hospital, just like we saw with that fictitious video in the fishing village in Newfoundland, it can be challenging. And so there's also the economic part of what we're talking about today as well. In Arizona, this hospital opened just prior to me becoming the director of the Center for Rural Health. This is way up in Palatka in the Hopi Nation. And so the reason I wanted to share this with you, this is a beautiful facility. It was brand new at the time. But the question is, where are the healthcare workers who work in this hospital? Where are they going to live? You are quite far away from the next community. Winslow would be the nearest town and Flagstaff the nearest city. And so whether you're a nurse, whether you're a custodial, you potentially could be driving, an hour, hour and a half just to get to work in the hospital. And so again, some things you would never think about in an urban setting, right? That there'd be lots of housing, apartments and stuff. But in rural, also sometimes even thinking about where are people going to live that work in the hospital. As I talked about, rural hospitals and clinics are vitally important economically and also access to care. So this is a map of the state of Michigan, and different colored dots to represent critical access hospitals. So those are smaller hospitals, rural emergency hospitals, rural health clinics, and fairly qualified health centers. And again, you can see most of the state depends heavily on these facilities. This is the exact same map for your state, for Arizona. And there's not quite as many dots because Arizona has about half the population, but you can see it's still vitally important. All those sorts of institutions, the 17 critical access hospitals in your state, are economic engines for those communities as well. So now I'm going to kind of transition. I think I've hopefully laid the groundwork, saying that there are some qualitatively, anyway, some challenges. I now want to start to go into our research program over the past decade that has kind of delved deeper into this topic. And the first one I wanted to share with you is this was during time I was at the University of Cincinnati, and I'd received a grant, and we were looking at the opioid pandemic, in which at that time, Ohio was one of the hot spots in the nation. The city of Dayton actually had the highest opioid overdose death rate in the entire nation. That was about an hour away from Cincinnati, where I was living at the time. And I ended up working with a fascinating individual called Diego Codros. One of the best parts of being in academia are those kind of interprofessional, interdisciplinary collaborations. I'm a pharmacist and a health policy researcher. Diego's a geospatial epidemiologist. He likes maps and databases and how far it takes to get stuff. And so I started working with him on this grant where we were mapping out different parts of the state of Ohio. And it just seemed kind of odd that even though, very similar policies governing physician practice and pharmacies, that there was these hotspots that we were identifying. And so the map on the left shows the relative risk of experiencing an opioid overdose, depending on where you live in the state. I know it might be kind of hard to see, but there's 3 circles. Cincinnati is 4, Columbus is 6, and Cleveland is 3. Those are the 3 big cities in Ohio. They all have about 2 million people. And of course, they're hotspots. But there's also, if you look at it, it's not just urban areas. It's also rural in different parts of the state, and then other parts that look just fine. The map on the right shows the change in relative risk over a 5-year period. And if you look at those same 3 cities, they're moving in different directions. Cincinnati, number 4, was pretty flat. Columbus, number 6, was decreasing in risk, while Cleveland, number 3, was increasing at risk. So even here, you have 3 urban cities, all about the same, but moving in very different directions. So we published this in Nature Scientific Reports. They just kind of, it just raised a lot of questions. Why is this so? In one state, you have almost these mini epidemics. It's not really just the opioid crisis or pandemic. Depending on where you live, it might look very, very different. We then took the next step then was to model this nationally. And this was published in PLS 1. And again, we really identified the same thing where across the country, kind of a mix of urban and rural areas where the opioid pandemic would look very, very differently. So this analysis actually went up to 2017. On a Monday this week, we just had a new paper accepted in the Lancet Regional Americas that updates this up to 2020. So that will be published probably in the next week or so that updates this to 2020. And we identified different hotspots in that geospatial analysis. So if you think back to 2020, right, about this time of year was a dark time for us all when COVID really hit. And so when Diego and I, we were in the midst of understanding the spread of that one public health pandemic, the opioid crisis, we decided to retool our entire research enterprise and focus on this new public health pandemic, COVID. And so a lot of the methodology and the geospatial techniques that we had developed, we then switched quickly over to COVID. And of course, I know we've got some other health policy researchers on this call. As you know, yes, it's important to publish in the peer review literature, but another tool are policy briefs. And so what we ended up doing was a series of policy briefs for the Ohio Department of Health to give them real world data to help them make decisions rather than waiting 6-9 months for a peer reviewed paper. And so this was the first one where we were looking at the impact of social distancing and how it differed and depending on where you lived in Ohio. It was not uniform. And we developed some predictive models. So this was our first policy brief. But I wanted to focus more on our second one, which was this one, where we identified differences in rural and urban Ohio. The map on the top center that has kind of the red and pink, those are the cumulative number of COVID-related deaths up to this point. And those 3 cities I mentioned before, Cincinnati, Columbus, and Cleveland, are all red. Those are what you would expect, right? If you think of COVID, a lot of it started in urban areas. But it actually doesn't map onto the graph on its immediate right, mortality risk. If you look at those 3 cities, they actually had lower mortality risk than many rural communities. So this was really fascinating to us, how you had different mortality risk, even urban rural. So this actually was a brief that we sent to the Ohio Department of Health on May 21st. And then probably the coolest moment I've ever had in my research career professionally. Oh, I think someone else maybe is not muted. Okay, there we go. Probably the coolest moment I've had in my professional career as a researcher. The next day, Governor Mike DeWine in his press conference, he was using our analysis. And that's a variation of the map that we sent him. And you can see, I'll read his quote. He says, disparities in health and healthcare are intertwined with social and economic conditions, such as race, ethnic background, age, and even geography, DeWine said. Knowing that some of our citizens are disproportionately at risk based simply upon their zip code is something that should shock all of us. We have an obligation to be even more mindful in our response to helping those at higher risk. So that was a pretty cool moment, again, when the next day after we sent the policy brief, the governor's using it in his press conference. We also then did a third brief later that year, doing a national analysis. So again, those same national geospatial things, and we identified very similar trends to what we saw in the state of Ohio. We still wanted to publish that, and so this national trends that we identified was then published in Annals of Epidemiology. To date, this has happened to be one of my more highly cited papers, and we looked at 3 different time periods during COVID, and not surprisingly, observed that it really hit urban areas in America first, and then spreading to rural areas. So while things were starting to get under control in cities, it was actually getting much worse in rural America. And so that's really the focus of that paper. We then continued our COVID research, and we looked then at the Delta variant. So this was published in JAMA Network Open. And by this point, the vaccine had come out. And so now we were looking at, what's the difference in kind of vaccine uptake across the country, and what's the relation of that to the spread of COVID? And not surprisingly, we found that in rural America, there was less uptake of the vaccination, and then higher incidence of COVID. And again, certainly we knew that rural communities were probably least prepared to deal with that because of a fewer number of ICU beds, hospital beds, ventilators, and such. So that, again, was in JAMA Network Open. We then decided to go a little bit deeper, and we looked at, is there a relationship of COVID vaccination coverage with different healthcare indices? And this, we looked at 3 different indices. These are not indices that we've created, so some of you may have used these indices in other analysis. The Healthcare Accessibility Barriers Index, the Resource Constrained Health System Index, and then the Social Vulnerability Index. And we thought there might be a relationship of one or more of these 3 to vaccination rates. And indeed, that's what we found. We found actually all 3 were highly correlated, and we identified what we call vaccination cold spots, in this case, where there's less uptake of the vaccine. And this is our national analysis. There's a few states that are white. Those are states we did not have reliable data from, so we couldn't include those. We could see both Arizona and Michigan, we did have reliable data from their departments of health. And this is looking at uptake of the vaccine. And you can kind of see these clusters, right? Really interesting. Some may even cross state lines, while these clusters tend to be within certain states. And again, there's a mix of urban and rural areas as well. Well, one thing that, if you talk about rural healthcare, one thing certainly that became even more pronounced during COVID was the use of telehealth or telemedicine. And of course, Arizona has been a longtime leader in that. When I was living in Arizona, Governor Brewer at the time signed the Telehealth Parity Act that provided more funding, reimbursement to physicians who see patients via telehealth. I remember when I was director of the Center for Rural Health, we did an event in Ajo, which is maybe about an hour and a half south of Phoenix, very rural towards the Mexico border. And their local fairly qualified health center, Desert Sunita, they rely heavily on telehealth. And so, for example, there's no at least there weren't dermatologists there at the time. If you need to see a dermatologist, you go to the health center, and then via video, you would speak to a dermatologist at the University of Arizona. So again, a great way, right, that to improve access to care. Now, having said that, I don't want to be a Debbie Downer here, but it kind of depends on whether you have access to broadband or not. And so this is a follow-up study that Diego and I did, where we started to look at what's the linkage of access to broadband to actually telehealth and different measures of social status. And so in this case, we actually looked at data from 3,108 counties in the United States. We looked at those same three measures that we looked at in the COVID study. So again, the resource-constrained health system, healthcare access barriers, and social vulnerability. And basically looking, is a relationship of those to access to broadband. And just like COVID and just like the opioid crisis, we started to identify hotspots and areas. So in this case, I know there's a lot to present here in the slides, so I don't want to put you to sleep or make it too complex. But if you look at the three maps on the top, those are each of those three indices compared to broadband access. And so where you see the dark green, that's where broadband internet access is low, and those indices are high. And in this case, if you score higher, that's worse. Okay, so you can see a theme among all three indices that's really the South, and in particular the Deep South, that really are struggling in these areas. We then broke the country into quadrants or clusters. And so cluster one are the areas that really have low broadband coverage. And on the bar graphs on the lower right, you can see, for example, cluster one that has the lowest broadband coverage is high on all three indices. Again, higher is worse. So again, this is kind of a troubling issue that you could argue that those rural communities that have the least access to broadband are also in many ways most susceptible to not having good telemedicine because they may not have the infrastructure to support that. So yes, telemedicine plays a role, an important role. I don't want to be dismissive of that, but there's also some practical limitations of that. It's not a panacea, it's not a cure for everything. So I focused so far on this presentation on the US, but I know Dr. Rahman and many of you are interested in global issues as well. So I do want to kind of change the focus now, looking what our research team has done globally. The first study I'm going to share with you, this was published in Annals of Family Medicine. It used data from a group called the Commonwealth Fund. And for those that may not be familiar with the Commonwealth Fund, because the next few slides all use data from the Commonwealth Fund. They are based in New York City. They are a healthcare foundation, nonpartisan. Their mission is to look at what other nations are doing globally and then to try to apply those lessons back to the United States. So in 2007-8, I did a one-year fellowship with the Commonwealth Fund in international health policy. And since then, they've been very gracious and have given me data every year from their international surveys. So this is from that survey, in this case, a survey of 11 high-income nations. We did a logistic regression trying to predict, essentially, what are the predictors for gaps in the coordination of care. And there were essentially 5 measures of coordination of care in this survey. And so we argued that if you're poor in at least 3 of those 5, then you're at risk. And you can see overall, if you look, the poor primary, that should be care, not Kate, coordination was 5.2%, but the US was about double that at 9.5%. Was more likely to occur in chronic conditions in patients actually younger than 65, which is interesting. And then you can see less likely to occur if their primary care physician often or always knew their medical history, if that physician spent significant time with them, if that physician involved them and explained things well. And of course, all those things were subjective. They're subjective things, but there certainly were some strong relationships that we found. So these are the differences across those 11 countries. So from left to right, Australia, Canada, France, Germany, Netherlands, New Zealand, Norway, Sweden, Switzerland, United Kingdom, the United States. And again, the United States, you can see, had the most patients with 3 or more coordination gaps. So differences across countries. Now it's interesting because this study, we didn't look at urban-rural differences, but this is where I want to start sharing those with you. So the next study, we started to look at, the previous study showed that there's important care differences between countries. That's probably not surprising, right? We know healthcare systems are very different. It's probably responsible for a lot of that. But also, are there differences urban-rural between countries? And so this was a study, actually came, these were graduate students, master's students, MPH students that took my graduate level course in health policy at the University of Arizona, ended up being published in BMJ Open. And so for this, we just looked at 2 of those countries in the Commonwealth survey, the US and the UK. And then we looked at urban, suburban, and rural differences in those 2 countries. And so you can see overall, the first bullet point, UK residents expressed higher confidence in both receiving effective treatment and affording care than their US counterparts. But within countries, some differences. So in the US, you can see suburban respondents were more confident in the effectiveness of treatment and in the ability to afford treatment versus both rural and urban respondents. Now it's interesting. I would say you probably wouldn't be surprised to say, okay, the suburban respondents are more confident in their ability to afford, but what about even the effectiveness? They also feel that the treatments work better. And then also you can see in the UK was more uniform. There weren't as many urban, rural, suburban differences. And again, that kind of makes sense, right? If you think of a system like the NHS, perhaps more uniform, whereas in the US, we don't have single payer. There probably are more regional differences. So again, maybe not the most surprising results, but it does confirm a lot of our assumptions. We then, this is a next study, was looking, this was published in JAMA Network Open, also used the Commonwealth Fund survey, also 11 nations, and this used the 2020 survey. And this is where we really dug deep into mapping these health disparities. And so this one, we created a logistic regression model, determined the association between health status and a variety of socioeconomic factors, affordability of care, access to care, area, so again, that'd be rural or urban, between countries, in age, group, and sex as additional covariates. This was actually the first time, to our knowledge, that the Commonwealth Fund shared that another researcher had used their data and started to look at urban-rural differences across all 11 countries. I can't tell you how complex this was because they had postal codes and zip codes, but they had never coded for these 11 countries before what's urban and what's rural. And every country codes it very, very differently. So this was hours and hours. I just want to acknowledge, in particular, Jennifer Waller, who is the biostatistician on this. I don't know how she did this. We have since shared our coding back with the Commonwealth Fund, and they're now using that today in current surveys. So that was kind of a cool, maybe a bit of a tangent I just wanted to share, but a cool side benefit of, because we were able to look at this data, they had the information, but they had never categorized urban, rural before. So in this case, we found 21 occurrences of significant geographic health disparities, but this is where it gets more interesting. In 13 of those cases, rural was actually a protective factor, and in 8 cases, rural was a risk factor. So this gives an example country by country. And so in this case, the US had the most geographic health disparities. So 5 of the 10 indicators, there was an urban-rural difference. But again, you can see in 3 of those cases, rural actually was protective, 2, it was a risk factor. Compare that with Canada, Norway, and the Netherlands, where we found no geographic health disparities, right? So again, kind of building on what we showed earlier with the US versus UK, you could argue, Canada geographically is huge. They have very rural and frontier areas, but we didn't find any differences urban, rural, as far as any of these 10 indicators, whereas the US, again, 5 of the 10, we found geographic health disparities. I won't go through this line by line, but this actually shows for each country where we found either where rural was protective or was better in urban. So just so, and that's included in that publication. So that's kind of the end of the research. I just wanted to wrap up the last maybe 5 minutes before we turn over to Q&A and just some practical implications. I always find any kind of research talk, you might be kind of thinking, okay, so what? What can we do differently? Neil, yes, you found urban-rural differences. You found them in state level. You found them nationally. You found them globally. You found them COVID. You found them opioid crisis. You found them broadband access. But at the end of the day, what does this really mean? So I thought I'd just share some potential solutions. And the first one actually goes back to, this actually predates me a little bit, my time in Arizona. But for those of you that have been down on the border in Douglas, right, which is what, maybe 2.5 hours south of Tucson, southeast. For years, they were having challenges recruiting pediatricians there. And I got to the point where the community was kind of just almost throwing out any idea. And at the time, American Idol was a very popular TV show. And American Idol always had this kind of one thing they did every year called Idol Gives Back, where they chose one charity and they raised money for that. And so I don't know who actually came up with the idea, but somebody said, "Oh, let's just try American Idol," almost as a last ditch attempt. Well, American Idol actually got that and said yes. And so you can see the picture on the bottom right. Simon Cowell, looks a little bit younger there, from American Idol, came down, raised awareness, raised some interest, and that led eventually to 6 pediatricians relocating and moving to Douglas. So I'm not sure where they are today. Perhaps they're back down to 0, or it's a challenge. But to me, that shows the lengths to which some rural communities will go. In this case, like saying, okay, we've given up, we've tried everything. Let's just try American Idol to recruit the physicians that we need. I think another solution, though, that's more practical. So obviously that was a pretty outlandish one. A more practical is really where you involve the entire community. And certainly something that's a great way for communities to come together are to do the community health assessments, which are required by the IRS. These are some pictures from when I was the director of the Center for Rural Health way up in Kingman, where we had people like, the assistant police chief and vice mayor and school board superintendent and others coming together and really articulating what are the top healthcare needs in the community, and then how can we meet those needs. And there's something that's really special when you have different perspectives of the community come together. This was a day-long session. You can see some of the sticky notes that came out of this. And so I think that's especially critical for rural communities and making sure that they have a voice. Every rural community is different. Their needs are different. And so making sure that we're being very attentive to that. The needs that came out of Kingman were very different than other communities in the state of Arizona. Another solution often, and I think this is because of such a shortage of primary care physicians, is let's make sure we're using other health professionals to their full scope of practice. Now, admittedly, I'm a little biased in this slide because I'm a pharmacist by background. But one thing that I've seen that's just been incredibly encouraging is that my home province of Nova Scotia, Canada, again, where remember I told you that a whole community had to build a physician office building and they still couldn't find a physician. In my hometown, they had medical students do sailing and still had challenges recruiting physicians. It's estimated that there's 100,000 patients currently in Nova Scotia without a primary care physician. And so what they've done, they've leaned hard on other health professionals. And if you're a community pharmacist in Nova Scotia, the government now pays for you to do independent prescribing, ordering lab tests, really becoming a primary care access point. So the picture on the lower left, this is a very old picture, Dr. Rahman. This is me around maybe 1994, 95. I'm a community pharmacist in my home small town. That's me there. What's really cool is that one of my former students ended up buying that pharmacy, and she's the individual in the red. And those are my 3 daughters with her. So that was a summer ago. So Pam Kennedy is now the owner of that pharmacy I used to work at. And her practice is so different. Yes, she still dispenses prescriptions, but most of her day is seeing patients, doing diagnoses of conditions like otitis media and things like that, prescribing on the spot, filling prescriptions, and also doing lab tests and other things, and with the full approval and support of her local physician. So she's not rogue kind of doing this, because the physicians realize if she's taking care of a lot of those conditions like shingles and smoking cessation and Lyme's disease, that frees them up to address more acute conditions. I think another solution for rural communities is we need to involve patients more. Now you could say this is true, of course, in rural and suburban area, or urban and suburban areas too, but especially critical in rural areas, again, where access to healthcare might be a challenge. This is a paper I wrote, a study with Henry Young, who I did my PhD with at the University of Florida. He was at the University of Wisconsin at the time. In that case, he looked at low-income patients with asthma in rural Wisconsin and looking at strategies to really engage them more in their care. And you can see what happened is that when they did these strategies to really what they call activate, but essentially make these patients super advocates, very knowledgeable, very engaged, that had positive, not just for their knowledge, but also improved their adherence and actually clinically their asthma control. So I think that's another often underutilized role is, how do we really engage patients in rural communities if they don't have access to specialists or other things so that they can take care and do a lot of self-help as well. And then the last thing as well, and this is kind of my final slide, I thought was appropriate for today's presentation of given Dr. Rahman's really global perspective, is that what I have found, is that many of the challenges, if we talk about under-accessed, underserved regions, healthcare systems may be very different, but I guarantee healthcare providers, health policymakers, academics in those other countries are facing the exact same problems. So when I was the provost at Augusta University, we started a collaboration with 2 universities in Scotland, Northern Scotland, University of Aberdeen and Robert Gordon University, that shared the same issues. We ended up having 4 virtual seminars. I ended up funding $100,000 a year in pilot grants, and we ended up evaluating this. So this paper was published last year in Nature Scientific Reports that basically kind of talks about the importance, especially in the value of these international collaborations. And so again, while the geography of Georgia, the United States, and Scotland, the United Kingdom are very, very different, man, there were a lot of similarities. How do you recruit nurses to rural settings? What do you do for economic development in those areas? And so again, we learned so much from each other, even though the NHS is a very different healthcare system than what we have in this country. So I know we've covered a lot. You might be feeling by this point in the presentation, but I did want to end there, so I'll stop sharing. Hopefully this has been valuable to you as far as just thinking about these issues of geographic health disparities. And maybe I'll end here, turn it over to Dr. Rahman, and then take some questions.
Thank you, Dr. MacKinnon. This is really deeply insightful, overarching picture of the United States and Western countries with serious implications and insights for developing countries. So this is really, really great. Thank you for doing this. So before anyone who has a question, please show me using the Zoom feature. Raise your hand and I'll call your name and you can ask directly. So while people are thinking, and Dr. MacKinnon, I have a few questions.
Yeah.
So one is that you laid out, this was I was also aware with your work on rural health in United States. One of the issue is you outlined that there are 3 major factors why access to healthcare in rural areas is not only it is lower than urban areas, but the gap is very persistent over time also. And one of them is population density, and there is nothing you can do about population density. Right. So, right, I mean, if that is the driver, yep, and it is not going to change, then the question is solution. You talked about 2 of the solution. One was telehealth, that that people
yep,
have tried to recruit. As long as density problem is not solved, the demand problem will be, it is not economical for a private healthcare professional. So telehealth and broadband access were 2 things you talked about. And these are the solutions in terms of meeting the demand. But what about, are there, so 2 questions I had. One is, has there been success stories? So for example, United States, you talked about Arizona, Ohio, Augusta. Are there success stories in US where rural health problem has been mitigated, access to healthcare significantly, and we can learn? If those are success stories, what has worked? And why I am asking is that it seems like there is an issue of also at the policy level solution. What is government doing? It is not just market solution, because everything you talked about, okay, healthcare is a market solution. We have a market system. There is a demand and supply problem. Rural areas have serious, adequacy of demand. So the market solution is not possible. And that's why it is gap persist. But what about policy level intervention? Medical care is, going to college is, medical college is very expensive. Why government cannot say that, hey, this is, you go to rural areas, your college is free, or incentivizing the payment, So like, for example, yeah, you go to Douglas, there is no enough demand, but government and state government can provide, hey, you will make this much at least, right, if you go to the route. So anyway, so I wanted your thought on that, and then I will have a lot of follow-up questions.
Yeah.
Yeah.
Well, yeah, I could probably give another hour-long presentation on like health policy interventions to help rural communities. And I should say, I hope this presentation wasn't too negative. I feel very optimistic about rural communities. They're some of the best places to work in. Obviously, I'm a product of a small town myself, I think you also have the ability to be innovative and flexible that you may not have in a large urban area. So I'm very optimistic. But yeah, to address your very specific question of what can we do policy related to improve rural health access, there are a lot of things. I'll just give you one practical example that happened in Georgia while I was there. And of course, a lot of states, and there's federal programs on student loan repayment and things like that, depending on where you live. But this, the Medical College of Georgia, which is part of Augusta University, where I was the last 4 years, really cool, ended up partnering with the state legislature. And the state legislature set aside $8.7 million a year, and then our president had to fundraise and match that. So theoretically, about $17 million a year. And those were given to medical students who met 3 criteria. They had to agree to stay after medical school and practice complete a primary care residency. Second, that primary care residency had to have rural components to it. So it just couldn't be, for example, in Atlanta or somewhere like that. And then third, there was a condition that they had to practice, I believe it was 3 years post-residency training in a rural community. And if they met all that, their medical school tuition was free. And so the first cohort of that, those were called the Peach State Scholars, started, I believe, in 2022, and they're ramping that up. Their goal is to have 50 medical students a year complete that program. Now, whether that works and how many end up staying, that'll be another question. I know, Dan and Jill and some other colleagues of mine on here do a lot of work on what are the predictors of whether a physician or a dentist ends up staying. And, 2 of the primary predictors are they from a rural area? And then where was the bulk of their most impactful clinical training, which of course for physicians would be residencies. And so that's the importance, again, especially with the Georgia program. It's the importance of actually making sure that a lot of their rotations and field training were in critical access hospital, federally qualified health centers, those things. So I'm a firm believer in that, but it does take, that's a big health policy initiative. In that case, the state of Georgia saying we're going to spend $8.7 million a year. We could be using that money to fix roads or improve broadband or whatever, but we're going to use this because we know the physician workforce is so critical.
And so thank you for that. So, Dr. MacKinnon, I had a follow-up question. One is that this may be you may not want to answer. You can choose it, decide it. One is that when you looked at international comparison, you compared with 11 rich countries, advanced countries, and your point was, which is also I have seen in economics literature, the rural-urban gap in OECD countries and US is of course at the worst, it is, but it is not very unsimilar. Do you think that one of the problem in US why we have rural-urban gap, and it has persisted, it is lack of universal healthcare? So let's say, for example, in Canada, you talked about, Canada doesn't have rural health, urban health problem. And one big difference is that they have universal healthcare. Other countries with which you have compared is they are similar to US, but US is very at the top of it, And one common difference is that they have universal healthcare, US doesn't have. So are we looking at that there is a solution in the room, but we don't want to talk about it because that's politically sensitive? So what do you think about it?
Yeah, no, I can wait. And even though I'm a university president, I'll take the bait here and weigh in. Yeah, I mean, clearly there's evidence of significant benefits of providing health insurance, right? And we can argue whether that should be private, public, the degree, but we know when this is just a basic kind of 101 thing, when folks have access to healthcare, they're more likely to use healthcare. They have fewer out-of-pocket expenses. And so in that triangle of quality of care, cost of care, and access to care is really enhanced. So what's interesting though, again, if I think about our partnership the last 4 years with Northern Scotland, again, a very different healthcare system. So there were some challenges that we were facing in the US that they were not, just because of the nature of that. But then other challenges, I would say, are outside of whether you have insurance or not. Just for example, can you actually recruit health professionals? Scotland has some real challenges, some very northern islands, like just getting people to move there. And if you think about it, not most, but certainly a lot of people would have a spouse or partner. So what are they going to do in those islands? Again, is there adequate school systems and things to do in those places too? So those were things that we had a lot of commonality with our colleagues in Scotland. We were trying to figure those things out together. But you're right. Certainly the US is an outlier when it comes to insurance. I would say, coming from having worked both in the Canadian and in US healthcare systems, I think if you look at Canada, and I would say to a lesser extent to the UK, yes, there's insurance, but can you really access care in a timely manner? And most Canadians, I think if you ask them honestly, they'd be really frustrated with that. And some end up coming to the US paying out of pocket because they're in long wait lists. My wife worked as an occupational therapist in Canada, and it wasn't uncommon for, and she was working in, her last unit was knee and hip surgery. It wasn't uncommon for the wait time to be 12 to 16 months for a knee replacement or hip replacement. So yes, there was insurance, but could you actually access the care? So, different issues. But yeah, I'll stop there because I know we've got some other hands, and that was a great question.
So now we have our next question is from Professor Charles Nusser. Charles, you can ask.
Okay. Hi. Thank you for the great talk. I'm thinking that the idea that rural communities have trouble attracting medical professionals, but they also have trouble attracting other professionals, such as lawyers or teachers or IT specialists. And I'm wondering if there's kind of solutions that have worked to attract those kind of people that might be transferred over to medical professionals. So, I mean, the idea is other fields have, other areas have the same problem, with attracting people to rural communities. And just wondering if there's any kind of useful knowledge from those other areas.
I love your question because often you're right. I think that's where we kind of myopic in healthcare, right? And if you think of 20 years ago when we were finally acknowledging the problem of medical error and safety, we were learning from aviation and other industries. How are they getting things right? So no, you're exactly right. And I think the other thing is that I hope I didn't paint too broad of a brush. Where we do have rural communities that are thriving, it's interesting here in the state of Michigan, where it's very different than Arizona, where we're losing population. But there's one small rural area of Michigan that is booming. It's called Traverse City. It's not a big city, it's about 30,000, and there's a bunch of communities north of there. So as far as recruiting health professionals, not a problem. Their problem is housing. No one can afford to live there because it's booming so much, right? So I guess
I've been there. It's a nice place. I've been there.
Yeah, it is. Yeah. Please come there in the suburbs. It's cherries and wine and all that. But I guess that goes back to the point I guess I'm trying to make is even among rural communities, because they're not all the same. Some, again, Traverse City, it's really hard to recruit school teachers there because where are they going to live? And so it's, again, any teacher would love to live there. It's a great place, culturally and stuff, but you can't afford to live there. So in that ways, it's almost more similar to like a San Francisco or something like that, because it's more the housing issue. So I think it depends on the rural community and the issue, but by all means, you raise a great point. We can learn from others and not just think in our healthcare box. Yeah, thank you.
Okay, thanks.
I'm muted. So just to follow up, Dr. MacKinnon, Professor Charles Nusser went away. I think he turned off his video. Charles and I are one. Charles is the director of Economic Science Laboratory at UFA. He is our principal. He is the giant in his field, experimental economics. But what is relevant, I wanted to introduce you. Charles and I are working on the issues of burnout that I had talked about.
Great.
So Charles, Dr. MacKinnon is also working on burnout among medical professionals. So we have something can follow up. So one thing, I just following up on Charles' point and Dr. MacKinnon, your answer. Has been a survey, I'm sure it is there, that why health professionals do not want to go to the rural areas. And the reason why I'm asking is that follow up to Charles' question, what is at heart is that there are two sides of issues, not only in US, but also I can tell you, since I mostly work in developing countries, one of the reasons why there is a rural-urban gap is variety of factors, quality of life. So like, let's say if you are a professional, you move to rural areas, where will your children go to school, right? safety issues, groceries, and other amenities. And so that is one factor that people don't want to go where all the facilities are not there, particularly for young professionals who come out of medical college and they want to have young children. So the quality of school they get. So that is one issue. Another issue, just I'm thinking out loud, given Charles' suggestion that the problem is for school teachers and other things, firefighters, other kinds of professionals going to rural areas. But there is is it the case that with healthcare professional, there is another issue. The opportunity cost for healthcare professional in urban area is very, very high. So if you are a medical doctor, whether it's a general practitioner or cardiologist, if you live in Phoenix, you can make $1 million. But if you go to Douglas, and even if your quality of life issues was not a problem, the trade-off is huge. For a kindergarten teacher, it is not. Probably at Douglas, you make $30,000 per year. In Tucson, you might be making $40,000. So is it the case that for healthcare, the reason why rural-urban gap persists is also about the opportunities, the money that make the urban areas?
Yeah, I know you've definitely hit something. I'll give you a very practical example of that. In Georgia, the Dental College of Georgia is the only dental school in the state of Georgia that was part of our university. And just like some of the challenges I described earlier with medical students in the state of Georgia, very similar in dentistry. And there was the salary difference and kind of the payer mix. So we have there's very lovely communities in rural Georgia, both along the Atlantic Ocean and the beaches, as well as in the mountains and elsewhere. But the payer mix drives a lot of that. So if you're a private practice dentist, what you can make, and then also the referral kind of with specialists and orthodontics, and there's more to it than you're not just a dentist yourself. It's also who you're referring, who's referring to you. And often those networks just don't exist in rural communities. And so you kind of get this kind of negative feedback cycle where, because the payer mix, referral networks, it just, even if someone's from a rural community and wants to go back, they almost have to do it knowing that they're going to take a massive financial cut. And then dentists actually, dental students have more student debt than medical students. So it's, you add that component as well. So yeah, you've definitely touched on something. And again, that's another kind of policy solution. How do we get more dentists working in rural areas? But yeah, it's and that's what makes this. For sure, most of you in this call have heard the phrase "wicked problems," which are these interdisciplinary, multifactorial problems. Rural health is definitely a wicked problem. It's not easy enough to say, "Oh, we'll just pay off all student loans," or we'll whatever. There's so many components of this that's why we're talking about this today, right? It's just that it's challenging.
Yes, thank you. So Julian go ahead, please ask.
Thank you for this great presentation. For those of you that don't know, I'm a professor at the College of Medicine at CMU. So I'm very interested because the mission and all the discussion, it's really about what we do at the College of Medicine. It's about underserved area, and especially in Michigan. I just wanted to react on what was said in the past. As you can hear, I'm French. And in France, we have exactly the same problem with the rural area that we have desert in France, which is smaller than US, but exactly for the same reason that basically the MDs and the future MD, they don't want to go to rural area. They want to go to big school, in big city, especially in France. So that's the thing. And I'm always very interested about, how we can attract actually MDs outside of those big cities in France, in US, and in Michigan, especially because it's really where we live. And Traverse City, I will not consider that as a rural area.
No, that's true. Yeah.
And so I'm not surprised that people actually want to go to Traverse City, which for everybody, it's a nice city. It's a little bit outside, but it's great. So it's what really can you do to attract the young people, the young MDs to be in those areas, except if they are born there, they probably want to go back. But what else can we do to really attract them? And that's why I'm very interested and passionate about this. So what would be your idea for the future generation and how we can really have MDs basically everywhere and not just in big city?
Yeah. Well, Julian, thank you for joining us as well. And I know that's reassuring to hear that, in your home country, France, it's a very similar situation, right? Yeah, I mean, I don't know if I have any, easy solutions here in like a 60-second answer, but I would say, again, if you go back to, and certainly Dan Dirksen or Jill Bullock can weigh in on this as well, but at least for where I come from, the two biggest predictors of whether a nurse, a physician, a dentist, a pharmacist, an OT is going to work in a rural community is, are they from a rural community? And to do a significant component of their training in that rural community. So if you think about just how different the worlds are, it's not surprising, going back to an Arizona example, you have a nursing student who grows up in Phoenix, comes to the University of Arizona to nursing school, does most of the rotations in Tucson. It's not even on their radar that I could work, in the Navajo Nation, for example, way up. It's such a different world. They might go there on vacation, right? Or something like that, but it's very different than living there. So again, it's really, those are at least the main two predictors. But yeah, there's a lot of other factors like we've talked about with, student loans and economic development, and is it a nice place? And even like you said, even if we have a beautiful place like a Traverse City or Charlevoix and Harbor Springs, which are beautiful communities, right? There's still a lot of challenges even in those communities recruiting. Those communities were some of the ones that were still health professional shortage areas on that map of Michigan. Yeah, but I'm glad you weighed in. It's good to hear about France. I don't, maybe it's bad to hear that France is the same. So just be désolé.
It's surprising because we have the universal health, everything, but it's still, I mean, my parents that are living outside, you just need like an hour driving to get to see a doctor, and it's everywhere, I think.
So this to follow up, Julian, and thank you for joining. And so this is where Dr. MacKinnon, I was asking is that even if we have universal care, still we are talking about market solutions.
Yeah.
Right? So what I mean to say is that if there is I feel like there are many countries for example, India. Everybody knows in India, healthcare is really poor, in bad shape. Prashit is our former student and co-author is in audience here. And so in India, healthcare is in terrible situation. But we do have one thing which is very unique. Because of government mandate, there are health clinics in rural areas every kilometers, every few kilometers. Now, it is different question how functional they are, how well staffed they are, and the quality of training. But when you mandate it, government mandated, then government is responsible for coming up with the cost and finding people, and then so that, hey, these rural areas have to have access to. In US, we don't have something like that. That okay, our rural community government, whether it is Arizona or Ohio or Michigan, that for every few kilometers, every few per number of people, we have to have one healthcare clinic, and that government is going to support it, whether it requires a variety of solutions, that you bring people from rural areas and train them medical school, send them to medical school. And they may not be as qualified, competitive to go into a medical school, but you bring people from those communities. They may not be as competitive to join a medical school, but you train them because they have lived there, they have experience there, they have affinity, affection, and attachment in the community, and they are more likely to go back. And you take care of their college education, And also about the government, when you mandate it, that each clinic has to be there, whatever the cost is, it is not about revenue and profit, So that kind. So yes,
that's great. I don't know if Prashit wanted to weigh in. I know he's again, we've got that bond of CMU and University of Arizona. He's been on the call here. Just anything, because I don't know, Prashit, you've done a lot of this research with me, especially over the past 3 years.
Yeah, absolutely. And it's very fascinating and also satisfying to see both of my mentors, one is hosting and one is actually being a guest on this session. So I'm really glad that happened. I have few observations to share based on our research so far. One is in rural areas, at least in US, the ratio of healthcare providers in terms of non-physicians healthcare providers, that is actually flipping. At least in Michigan, lot of nurse practitioners and maybe physician assistants. So their number is gonna be more as compared to physicians. So that could be one solution, which is coming up. So in lieu of having physician at place, maybe other healthcare professionals are taking place there and maybe serving the need. And just going back to the solution, the government mandate, practice we have in India. So something similar we have here in United States as well, maybe not in healthcare, but if you look at the aviation industry, there are some flights which are mandated by government, and some places, even the flight goes empty, they have to serve that area. So something similar can be also think of in US as well. So that is something I wanted to add.
Thank you, Prashit. Great to see you, and thank you for your kind words, and we will follow up later on. So now our next question is Professor Candice Gibson. Candice, please feel free to ask question directly.
Oh, thank you. I'm also at the College of Medicine at CMU, and really enjoyed your talk, Dr. MacKinnon.
Thank you.
And I'm recently from Canada. I spent most of my life in Canada as well, in Ontario, and was at the University of Western Ontario's School of Medicine and Dentistry. And one of the solutions that was tried there and across Ontario was the idea of satellite medical schools. So that idea where you said the two main factors that determine where people practice is kind of where they're from and then where they got the training, that seems to have been somewhat successful. We have a satellite school in Windsor, and in fact, Ontario, they put a school in Northern Ontario, the Northern Ontario School of Medicine, and it really predominantly takes students from Northern Ontario and First Nations students and whatnot. So I'm not as familiar with what they're doing in the US, but is that a solution that could be applied? It strikes me it's the same idea of mandating the health clinics in those rural areas. This would be putting the actual training in the schools in those rural areas.
Yeah, no, thank you for sharing that, Dr. Gibson, and 100% agree. At the Medical College of Georgia, where I was before, there's a center kind of mothership, I guess, if it were, of 204 students per class in Augusta, but then 6 satellite locations. And so the students they do the first 18 months in Augusta, and then the rest of the training is in one of those. Some stay in Augusta, but then because of the necessity of some rotations that need high volumes of in a tertiary medical center, but most of the rest are across the state. So you're exactly right. At the University of Arizona, I don't know if you still have that there now, Dr. Rahman, but when I was there, they had something called the Rural Health Professions Program. Medical students, pharmacy students, nursing students, and public health students could do it. I taught a course that was part of the curriculum in rural health, and as part of that, the students took special courses in rural health and did more of their clinical rotations in rural communities. And then the AHEC helped fund some of those because there were extra costs to the students. But then when they graduated, they also got a certificate in rural health. And so it was a win-win for everyone. So I love those kind of things. Just like Dr. Gibson, you've described where the clinicals are more in those communities where we want them to live and serve. And then if you can combine that maybe with some coursework and other financial incentives, because sometimes it does cost more for the students to do those more remote rotations as well. So we also have to, we can't be an undue burden on our medical students as well.
Right.
Yes, we still have the rural residents, the rural health professionals.
Oh, good. Good. Thank you, Jill. Thank you.
So that's good. So the other difference in Canada is this use of other types of health professionals, which in fact I quite like seeing this in the States with the DOs and the nurse practitioners and physician's assistants. And in Canada, there's been a real big reluctance and pushback among the physicians, to even not open up. That was one thing we tried to do at Western, was open up a physician's assistant program, and didn't get anywhere with it. So it's good to see that in some instances, like pharmacy, for instance, there is this increase in the role. But sometimes the worst, the people who are kind of most of a hindrance are those people you're trying to help the most.
Yeah, and I can understand, for a lot of physicians, certainly it is, it's a big change in the practice model, right? And,
Right.
when reimbursement and other things are tied into that, I get that. But at least, I would say, for at least my hometown of Bridgewater, if Pam Kennedy was on this call right now, she would say this would not have worked without the support of her local physicians. There's such a shortage there. The wait times to see a primary, a lot of people in Bridgewater, I wouldn't say most, go to the emergency department for their primary care because you just can't get an appointment. And so the realization that, we need all hands on deck. So
Mhm.
whether that's a pharmacist, whether it's a nurse practitioner, a physician assistant, everyone needs to play a role to meet the volume of need that's out there. Yeah.
Right.
Thank you.
And that's
Thanks.
great. So I think at some point, Mira and Professor Mark Nichter had hands up. If you are still want to ask that question, please ask. Mark?
Yeah, hi. I'm a professor at Central Michigan University. In the first part of my career, I was in hospital administration and I was the CEO of a hospital in downstate Illinois, considered a rural hospital. And the challenges were significant in terms of recruiting, not just physicians, but other, of course, healthcare professionals. But we found over time that you're not just recruiting the individual. If they're married, you're recruiting the spouse and their family. And the older the children are, the more difficult it is to get them to relocate. So we ended up developing a good approach with the community. Community leaders pulled together and really helped us put the best step forward whenever possible. But it's a hard sell, and every hospital I've ever worked at, that's in Atlanta, Georgia, here in Michigan, it's constant physician recruitment, and it's just getting crazier in terms of what the starting salaries are and the expectations, how many hours they're going to work per week. More and more doctors are talking about wanting to be employed, wanting defined hours, as opposed to getting out there, either starting their own practice or joining an existing practice and being partner bound with that practice. It's just a whole different thing now. And I'd just like to make a point. In our community, we developed a loan program for students who graduated from our high school and they went on to like University of Illinois or other places. And if they were pre-med, we'd make sure that they were on our radar screen. And we had a situation where they could have their loan repaid within 5 years, 20% per year, just by coming back to the community and working. And we had more luck with primary care than we did with specialty. When I say luck, I mean that we had individuals who would take the loan, but if they chose the loan, and they always have the freedom, right, to go to do whatever they want. If they took the loan and they went into a specialty area, the odds were that they weren't going to come back. And then it was okay. They'd pay the loan off anyways. So there's always that issue too. People have the freedom of movement, even if going into medical school, they think that's what they want to do. They can change their mind down the road, and that's just a practical reality. So I love the idea. I wish that we could be more directive at the front end. Hey, yeah, you'll get into medical school, but here's the deal: you have to be in primary care, and you have to be in this service area that that where we have a shortage. But as of yet, I know organized medicine would say, no way, you can't do that. It doesn't work that way.
Well, no, thank you I mean, it sounds like you've got a wealth of experience, Mark, on this topic, a very practical level and the leadership roles that you've held. And, I won't comment on everything you said because you covered a lot of good things there, but just one thing, you mentioned there about just the fact as we're thinking for many physicians and others, it's not just even then the spouse, it's the children and dependents too. And for those of you that have ever moved, like my wife and I have a few times, one of the first things you do is what are the test scores, right? Where you're moving. And
Right.
so again, how solid is that educational system? You know, I came from the city of Augusta, which is a city, not a huge city, but the test scores in the city of Augusta are horrific. And it was a major concern of all employers, the university, the military base there, other industry, because, you know, if your public school system is failing, who wants to move there? And so again, think about this concept of a wicked problem today isn't about fixing the education system, but it, especially in a rural community where you don't have that choice. You may not have like an urban area where, okay, if it's not in your district, you might be a private school or charter school. In a rural, basically, you might have an N of 1 as far as the number of schools you can choose from. So yeah, Mark, you hit a lot of good points there. And it sounds like we need to have a follow-up conversation at some point too. So
No, that'd be great. Thanks.
Yes, thank you. So now our colleague Mark, go ahead.
Yeah, just a couple of comments. I'm a medical anthropologist that has worked in family medicine and the School of Public Health here. And I've worked quite a bit globally as well as nationally. More than that, though, I'm fascinated by this discussion because I am a creature of this. I mean, my father grew up in an orphanage. He became a clinician because of World War II. We moved to rural areas of the United States where there was no other practitioners. And we did this for 10 years of my life until I was 10. And then my mother put her foot down and said, look, this kid's never going to get a good education. It wasn't so much a question of food or transportation or at that time internet, because it didn't exist, but it was always education, what's going to happen to the kids. So I'm very sensitive to this issue. I have a couple of comments though. I mean, in terms of solutions, there's not that many options. I mean, there's just a couple, right? One is you can have healthcare extenders, people who are, you know, paraprofessionals who come from rural areas and are likely to stay there because they can do well there. They already have a network, they're connected. And this is, for example, I've worked in India for decades, and this is what's happened in India with decades. And they have used Ayurvedic practitioners, and they've used other types of practitioners to staff those rural health offices that were discussed before. There's always pushback from professionals when you do this because of, you know, for many reasons, ranging from political reasons to technical reasons in terms of being able to provide good quality of care. So that can be changed a little bit with better telecommunications where people can check in with people. We do that in Arizona, right, with EMTs. EMTs are fine. They can staff some of these areas as long as they have connection and they have a practitioner that is willing to backstop them, right? So one of the things that hasn't been talked about here in terms of young physicians is that everything is about the young. Nobody has talked anything about older practitioners, practitioners who are disgruntled. I've done a lot of work not on burnout so much. I think you have to really be careful with the word burnout. I think what we're seeing in the United States right now is moral distress and moral injury with a system that just doesn't work. And if you look at the statistics of practitioners, especially doctors in certain professions, what they're most concerned about is that they're not able to practice the kind of medicine that fits their value system. And it wears over time. Now, when you're young and you have kids, you will put up with that, right? Because you have to make money, you don't want to send your kids to school, so forth and so on. But as you get a bit older, that wears a bit more. And I'm very interested into the idea of also having incentives for older practitioners. When I say older now, I'm not talking about very old, I'm talking about 55 plus, right? Who might want to have a career. They already have made some money. Their kids are perhaps already in school. There could be incentives for them to be able to send their kids in school if they still have older kids. But using these as a backstop in combination with these healthcare extenders, these rural health practitioners from areas that want to live there, but it's having that oversight and that next level of support that might facilitate against a pushback of other professional organizations that say, no, they're not equipped, they're not educated enough. But if they have backup, and if you've got access now via the internet, this might be another model. I just wanted to throw that out there as a possibility for you.
No, thank you for that. And I think you nailed it exactly. There's not one simple solution. So we almost need to kind of take everything and you know, it's too bad we can't do pilot tests of, you know, different settings and see what sticks or not. But no, you've exactly hit it. I think it's a great idea. And, you know, it sounds like just with your own personal background story is fascinating as well. So I know, Dr. Rahman, we're just a little past the 90 minutes.
Yeah.
I know as a president, I do need to do another meeting. I apologize, but also there's been some great comments. I see Dr. Norris, if you want to follow up with me directly, you can. We didn't get a chance to answer that, but maybe I'll just turn it back over for closing remarks from our host.
Yes, so thank you. We are already way past one and a half hour. So this has been really a wonderful discussion. Thank you, Dr. MacKinnon, for deeply insightful talk and all the excellent questions from colleagues from Central Michigan University, University of Arizona, and our former students. This has been really insightful, and thank you for doing it. And I hope, Dr. MacKinnon, that we will have you for IfAD Public Talk in person if your schedule permits in the future. And I look forward to exploring collaboration with you and the initiative I lead here. So thank you, everyone. Have a wonderful day. And thank you again, Dr. MacKinnon. Have a good day.
Thank you. Take care. Thank you.
Thank you.